All right, everyone. Welcome to the South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center. And our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance for muting your microphone once the presentation begins for our virtual attendees, being attentive to the presenters and engaged in the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session evaluation form at the end. Today is December 6th, 2023. Our activity code today is 10093226. I'll leave that up on the screen for just a minute. You can register for CME credit via text by texting your email address to the number on the screen, 844-502-1338, and then texting attend 10093226. You must register for each session by midnight in order to receive CME credit. All right. Here's some information about that new CME system. Again, the activity code for today is 10093226. You can access your CME transcripts via the instructions on the screen. You can just log into the CME office's website and select My Transcript and Print. Should you have any questions, you can access it, or you can contact them. American Academy of Family Physicians members can use your AAFP login to claim credit for this activity online at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Our Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Dr. Kevin Proud has no financial relationships with ineligible companies to disclose. And now Dr. Nato will present our speaker.
Thanks for the opportunity to introduce Dr. Proud. Dr. Proud completed his internal medicine residency at the University of Michigan in 2010 and subsequently completed his fellowship in pulmonary and critical care medicine at Case Western in Cleveland, Ohio. He joined the pulmonary faculty at UT Health San Antonio in 2014. He served as an associate program director for the internal medicine residency from 2019 to 2022. He currently serves as the program director for the Pulmonary and Critical Care Fellowship at UT Health San Antonio. He teaches point-of-care ultrasound at the national level and has test-and-more status with the National Board of Echocardiography in the critical care echocardiography. All right, I'll turn it over to Dr. Brown. Thank you very much for coming.
All right, well, thank you for having me. I'm very excited to be here. So when I was a fellow, my institution was just beginning to dip their toes in the waters of performing ultrasound, point-of-care ultrasound. And when new technology is entered into medicine, sometimes it creates a very interesting juxtaposition. So I can remember a time when, as a fellow, I was credentialed to perform thoracentesis unsupervised. But if I wanted to look at it with the ultrasound first, I had to have my faculty there with me. So it was a little bit of a strange time. Also kind of complicating that, it was interesting that my faculty were learning along with me at the same time. So we'd have the radiologist there with us. They're looking, my attending is looking, I'm holding the probe and the needle. And at some point I started to wonder, okay, who really has more experience at this point? So as a result, I'm very excited to teach you about lung ultrasound, because the use of point-of-care ultrasound in the last decade or so has really just exploded. So today, I'm just happy to share with you, after multiple courses, learning through direct mentorship here and about now almost a decade's worth of experience, kind of share with you my thoughts and experiences. So before we do that, I'm just curious, how many of you use point-of-care ultrasound right now? So we got some work to do. Good. And how many of you use it for the lungs specifically of those? Sometimes. Good. All right. So we'll go through this. So here's the objectives for today. So by the end of this, you'll be familiar with the concepts and benefits of point-of-care ultrasound. You'll know and understand the optimal machine settings and transducer selection for performing lung ultrasound. You'll be able to properly position the patient and examine them with the ultrasound. And you'll be able to categorize the finding that you see and correlate that with disease processes and clinical pathology. So point-of-care ultrasound is essentially just using the ultrasound machine by the person who's actually making the clinical decision. So it allows someone to be able to make decisions in real time. One of the other big benefits is it actually puts you back at the bedside. It's probably the only technology that I know of that actually draws you closer to the patient, makes you spend more time with the patient. The use of it really started back in the 60s and 70s with cardiology and obstetrics. And from there, as machines have gotten cheaper, better, more portable, it's just expanded into literally every realm. So even now at a lot of the national courses we teach, it's gone from every subspecialty of medicine, even into having the advanced practice providers. Med students are learning it in school now. So it's really something that's useful and continues to expand. Really, the only field that so far has no clear use for it is psychiatry, as far as we know, but every other field has something. So how does that workflow work? So the traditional workflow, if you were ordered to something or order a test like an ultrasound, you would be there seeing the patient, think, okay, I need the study. So you order it, and then the technician comes and performs the exam. And then once they're done, they upload the images. They get read by the radiologist or cardiologist. The expert generates a report after reading it, and that eventually gets back to the clinical provider who's making decisions. So with point-of-care ultrasound, it skips most of those steps, and the person who's making the decision, who needs the study, looks at it, performs it, and interprets it all in that step, and then can make their clinical decision. So it saves a lot of time in a lot of situations, and it's actually really important for places in rural areas where they don't have experts in a lot of things. We actually did a virtual training course with practitioners in Alaska who were learning how to do it, and they were such small hospitals that it made a big difference whether or not they'd have to ship them to the mainland or not. So ultrasound, just to give you a little bit of background with lung ultrasound. So the ultrasound, the sound waves obviously have to travel through the media, and certain medias are very good at transmitting sound waves. And for example, fluid density, soft tissue density. One of the reasons that it started with OB, obviously a lot of amniotic fluid, you can see really nice images. The lung, however, and air is a very poor medium for sound waves to go through. So there's a lot of attenuation. Sound travels very slowly through the air. So historically, people thought you really can't use it to look at the lung because it's just air filled and you won't be able to see much and generate a lot of artifacts. Since then, we've learned that the artifacts that are generated actually can be useful in determining what kind of pathology you're seeing in a lot of situations. So it's really developed and become useful. So how do you actually do the exam and use the ultrasound? So we'll start with just talking about a little bit of the equipment settings. So anytime you have an ultrasound in front of you, I always say you want to pause and do a quick ultrasound equipment check. So there's a few things you want to look at. You want to determine what kind of mode the machine is in. So the exam type it'll tell you, there's different types of exam. This one here is abdomen. They do have a lung ultrasound exam, but I don't really recommend using that. Most experts across the country don't like it. It has to do with the harmonics actually degrade some of the artifacts that we use. I'll show you an example of it and you'll see directly why we don't use it. Usually we do most of our lung ultrasounds in the abdomen mode. And you want to make sure then that your orientation marker, which is this dot, is over on the left side. So there's two conventions. The radiology convention always puts this little dot over here on the left-hand side of the screen. And cardiology convention puts it over here on the right-hand side of the screen. So you always want to make sure it's on the left. And that orientation marker correlates with the orientation marker on the probe so that you know what direction you're actually looking at things, and it helps you orient when you start to look at this. The way I remember that the radiology convention is supposed to be on the left side is it's just like looking at a chest x-ray. When you look at a chest x-ray, the left-hand side of the screen is the patient's right. Same with ultrasound, because by convention, the orientation marker on the probe is either supposed to be pointed towards the patient's right or towards their head. So as a result, the left-hand side of the screen correlates with the patient's right side or their head, depending. You want to look at the depth to make sure. So when you're doing most lung ultrasound, you want it to be somewhere around 12 to 15 centimeters worth of depth, which is demonstrated over here on the side. And then you can tell a little bit about which transducer you actually have hooked up to the machine by the outline of this. So the triangle or sort of trapezoid shape is going to be the phased array. If it were flat across, it would be the linear array probe. So once you have all that, then you can kind of proceed with selecting your transducer. So you can actually do a lung ultrasound with virtually any probe. They all have some uses, from the big curvilinear, what some people call the abdominal probe, it would just give you a larger field but have a lot more ribs in the way. To down thing, in Europe, they use a lot of what they call a microconvex, which just has a little round tip that you can get down into the rib space. But in the US, far and away, the most common is going to be this phased array transducer. And some people call this the cardiac probe. It's useful because it has a small footprint, so it can fit down within the ribs pretty well. And it's a low frequency transducer. So if you know ultrasound, lower frequency means a little bit lower resolution, but you can get a lot more depth of the image that you're seeing. The probe below is what we call a linear array transducer. So it's a high frequency probe, gives you really high quality images, but it can't go any more than usually about 6 centimeters worth of depth. So it has a role in lung ultrasound, but mostly when you're specifically looking at the pleural line, and I'll talk to you about why we do that. But by and large, the one that we use the most is going to be the one on the top here, the phased array probe. So how do you actually do the exam? So when we perform it, you basically hold the transducer like a pencil. You're going to have the orientation marker on the probe mostly towards the head, but if you were going to do a transverse view, you turn it towards the right, but mostly towards the head. And then you put it essentially perpendicular to the chest wall. And sometimes you have to do a slight tilting of the probe back and forth to really get your ultrasound beams as perpendicular to the pleural line as possible. That's the key. And just keep in mind that, especially in the US, where obesity is a big problem, the chest wall does not often correlate with what the pleural line is doing. So you have to sometimes move it around and tilt it back and forth to really see some of those A lines pop out, and then you know you're as perpendicular to the pleural line as it can be. But we'll go through that a little bit more in just a minute. Where do you actually do the exam? So there's a lot of different protocols out there in the literature, some that range from as few as 4 points on one side to maybe 16 points. There's a few papers that even talk about doing sort of a lawnmower style approach where they put the probe on the chest and the rib space. They slide it all the way down the rib space, move down the next one, slide all the way back, and really scan thoroughly. So you kind of, in my mind, it depends a lot on how much time you have and how concerned you are about a specific area. If there's a particular area that I know is abnormal or I'm worried about, I spend a lot more time looking there to really do things like take measurements, get detailed information from. Most of the pathology tends to accumulate in your posterior inferior region down here right above the diaphragm. All of these protocols, by the way, tend to divide things up pretty simply into the anterior portion, lateral portion, and then the posterior portion. So any of those things really work, and it's just a matter of how thorough you want to be, how many rib spaces, and how much in that rib space you want to look at. If possible, it's always a better exam if the patient can sit up, particularly posteriorly. But in the ICU where I work frequently, we can't do that with them, so we can sit them up even semi-recumbent. It's usually useful. So when we do the exam, usually what we try to do is maybe 1 or 2 rib spaces in each of these things. So we would do one up in the anterior lung zone here, maybe 1 rib space, look there, and then just slide down to the next clavicular, intraclavicular line and intervertebral space and take a couple of images. Then we slide over laterally, take 1 or 2 rib spaces, take a look, and then bury posteriorly. When I'm teaching this at the course, I do my best to try to remind people that you should really think of the ultrasound as more like a flashlight than actually kind of what you're working with. So if someone could not sit upright, but you really wanted to rule out a pleural effusion, you really have to get posteriorly on the patient's skin and almost push the probe under them into the bed and look upright. So that helps out a lot. Just to help you with orientation a little bit, so when you're looking at the screen, remember at the top of the screen is going to be the closest part to the patient. So up here is going to be near the transducer and the patient's skin. And that's where your flashlight is, kind of looking down. So as a result, in the bottom of the patient, anything at the bottom of the screen is going to be deeper into the patient. So it's a deeper structure, more inside, right? So like I told you, that based on the convention, if you're holding the probe right, the left side of the screen should be towards the patient's head, making the right side of the screen towards the patient's feet, just to give you some orientation. So that's the crux of how we actually perform the exam. So now how do we actually interpret it? So it really boils down to a few basic patterns that you're looking for. So one is what we call A-line pattern, there's the B-line pattern, C or consolidated pattern, and then looking at pleural effusion. So we'll give you some examples of all of these things. Easy way to kind of remember it, the A is going to be something that involves a more aerated or air picture. The consolidated pattern is going to be as the lung gets more dense and consolidated, obviously. And then I say B, it stands for in between, because it's situations where the lung starts to get a little bit more dense than pure air. So it's really just the ABC. That's all you have to remember, okay? And like I said, initially people used to think that ultrasound was pretty useless in the lung. A lot of that changed in the mid to late 2000s when Dr. Lichtenstein first published a study in an ICU. He went into it for any patient that was admitted to the ICU for respiratory failure, and he knew nothing else about them, but he performed his lung ultrasound. And he was able to categorize it correctly into one of these things with about a 90+% accuracy without knowing any more information than that. So this is really how we try to break it down. So when we see the A-line pattern, remember A is for aerated things, and there's good lung sliding, meaning the pleura is nice and intact. Things that he would put in the differential at that point would be asthma, COPD, PE possible, but you'd have to find some other evidence of PE to really make that distinction. If they were admitted for respiratory failure and they had the A-line pattern, but there was no pleural sliding, then that would be consistent with a pneumothorax. If he saw the B-line pattern and it was diffuse in both lungs, that usually meant either ARDS or cardiogenic pulmonary edema. And if he saw a B-line pattern in one focal zone of the lung, say right lower lobe, right upper lobe, but the rest of it was an A-line pattern, that would be highly suggestive of pneumonia. And if you see a dense consolidated pattern, that also can go along with pneumonia or potentially atelectasis. And then pleural effusion, whole different ballgame, but we'll talk about that as well. So we'll go through each one of these patterns in detail so that when you see it, you can know about it. So the A-line pattern, A-lines are essentially these recurring horizontal lines that occur at regular intervals, okay? And they're always deep to the pleura. So just to orient you, the top again is going to be the chest wall here. You're going to see these dense shadows. So there's rib right here, and that blocks the sound wave from going down. So it creates these dark black areas on either side. And you want to center that probe basically over in between two ribs so you catch a little bit of it, helps you orient exactly where you are. The bright horizontal line, the first one that's just below the ribs, is going to be that pleural line. And then these A lines are going to be below it. And they tend to get more and more faint the deeper you go. And they should be at, like I said, regular intervals. If you're not seeing them, usually it's a matter of tilting back and forth to really get perpendicular to that pleural line. So why do these happen? So remember, you're not actually looking at the lung with this. You're actually looking at an artifact. So what happens is the pleural line is a dense structure with air density behind it. So as a result, a lot of the sound waves leave the transducer, they hit that pleural line, and with the air behind it, most of them reflect back to, or a lot of them reflect back to the probe. I shouldn't say most, because does anybody have a sense of roughly what % of sound waves come back to the transducer in ultrasound? 80%, 50%, less than 10%. Very good. It's about 1%. So even less when you count the reflection and stuff. So some of them bounce right off that pleura and immediately come back, which is why the pleural line is usually the brightest. Some of them bounce off another reflector like the skin, then back down to the pleura and then up. And some of them that do that a few times. The ultrasound is not smart enough to know that's what's going on. All it knows is those sound waves are taking longer to come back. So it generates these lines. Now that only happens when you have a dense reflector with air density behind it. Okay, so that's how you know that there's air down below the pleural. You might ask, why isn't this one up here? And that answer is very important, but very simple. So you have to know that obviously the pleural line is below the rib. So you have to identify the rib and the rib shadow and look about ½ centimeter below that. Anything above that is going to be some kind of other reflector within the soft tissue. So just to review a couple things about that. So remember, you're not actually seeing the lung. You're basing this on an artifact that happens with a dense reflector and air density behind it. So you can see A lines in the setting of a pneumothorax. The pleural line is generally going to be the brightest because it's going to reflect more of the sound waves than its A lines. And then, like I said, it's really important to tilt that probe back and forth to really get them to pop out and be as bright as they can. That's usually the thing that people aren't seeing. If you're looking with lung ultrasound and you get what's called a non-A, non-B pattern, that's essentially non-diagnostics. You're just not lined up quite right. And then we use these A lines in the context of lung sliding. So what is lung sliding? So currently, ultrasounds do not have high enough resolution to differentiate between the parietal and the visceral pleura. But when the two slide across each other, it generates another artifact and looks like motion. So this is just another example. So in this one, we're actually using the linear array probe, and you can tell that because it's straight across the top rather than that triangle shape. So this is a high frequency, high resolution probe. You just can't get nearly as much depth. But the nice thing is it gives you a very crisp, pretty image of that pleural line. So again, we're kind of looking up here is the patient's skin. This little arc here is going to be the rib with the rib shadow, making this bright white line the pleural line. And you can see how in the video it's kind of shimmering back and forth as the patient breathes. That's the two pleura sliding along each other. So we use that to say that those two pleura must be touching each other, and that's how we know that there is no pneumothorax there. This is just to highlight how important it is to be able to identify your landmarks, to know which one's the pleural line, because in some patients you will see a lot of different lines up in the soft tissue. Like even this one could be a little bit confusing, but you have to be below, about within ½ centimeter below the front of the rib there. That's very important. This is essentially the same thing, only we're using the phased array probe. So you can see that the depth is a lot deeper. It's down to 13 centimeters, not nearly as clean and high resolution as an image, but you can still identify the rib shadows, and then the bright white line at the top is the pleural line. And you can see a little bit of that shimmering kind of going back, sliding back and forth as the patient breathes. So in that situation, you can also rule out a pneumothorax. And if you see it with the phased array transducer, you don't really, there's not a reason then to switch to the linear array to kind of confirm it. If you see it, it's there. This essentially rules out pneumothorax in that location. Definitely one of the limitations of ultrasound is if you do have a pneumothorax, you can't really tell much about the size of it because the lung can press down and further in, giving a bigger volume, but the ultrasound can't tell that. It can really only tell within a rib space whether or not the two pleura are near each other. But it's not specific for this. So there's areas where you might not see any lung sliding, and that would be in situations like apnea if the patient's not breathing. So occasionally, right after bronchoscopy, if they're still under general anesthesia and the anesthesiologist has them set to a low rate, we'll look and you'll literally have to wait the whole 6-7 seconds before the next breath goes in and you won't see anything. Similarly, in the ICU, if we intubate someone and then we do a right maiden stem intubation, there's no airflow to the left lung, you might not see any lung sliding because there's no air movement on the left side. So you just have to keep that in mind. Really severe bullous emphysema where there's no air movement to one portion could also give you a situation where there's no lung sliding. And then dense areas of pneumonia might not have lung sliding, but you'll usually see other things that will tell you it's pneumonia. So this is just to give you an example of what it is if there is no lung sliding. So again, we're using the linear wave probe. It's straight across the top. This is pretty high resolution, so you're getting nice crisp images. You see the rib and then the rib shadow following here. And then you can see these different recurring lines. But if you look at the pleural line, there's really no motion. Some of it is moving because the patient's taking big movements. So they're moving all their chest wall muscles. And you can see that if you look at the whole image, like everything moves together up here because the patient's working to try to breathe. But you tend to get a little bit brighter A lines in pneumothorax, but definitely not papillomonic by any means. But the lack of the sliding is really important. And hopefully you can see that better on this one. We'll see if that second image will go. There we go. Okay, so if you compare the two, on the right-hand side of the screen, you got that nice shimmering sliding pleura. On the left-hand side of the screen, none. So we use this a lot in the ICU because you got to know quickly sometimes if whether or not they have a pneumothorax, and that's helpful. This is another example of something that you can see. This is what we call a lung point. So if you had to sort of describe it, you'd probably say, if you look at the pleural line, part of it is clearly moving and sliding along, and part of it's not. And if you think about it, the part that's not is more towards the patient's head, right? It's based on the orientation mark of what you said. So this is what we call a lung point. This is the exact place where the two pleura start to separate in a pneumothorax. So on the bottom half, towards the more dependent area, the two pleura are still sliding along each other. And then above that, the lung starts to pull down in and the two pleura separate. So you no longer get that artifact up here on this part. And this is the only thing that really does this is pneumothorax. So I hesitate to say anything is ever purely diagnostic in medicine or 100%, but this would be very, very suspicious for a pneumothorax if you get the right context. M mode is something else that we can use. So this we're just telling the ultrasound it's a specific mode where we tell it, okay, look at this line here, and only things within this line, structures relative to each other, and then it's going to create a rolling continuous image of all these structures next to each other. So the more you use ultrasound, the less you start to use this for lung sliding, but in the beginning it can be kind of helpful. I think it's real use for people in the past has been if they're trying to archive something that's a video over time as a still shot and print it out and put it in the chart. This is really the only way to do that. But it's helpful in looking for pneumothorax because it's going to give you images like this. So in that situation where you have that shimmering pleura, it'll be here, and then it generates this artifact down here that is a little bit more broken up. If there's a situation where there's no movement from no pleura, it's going to look more like these horizontal lines, very static. Go ahead.
Yes, so that's one image, one place. So how many places do you have to check to feel confident that you're not seeing this lining?
Yeah. So that is a great question. It's just asking, how many places do we usually look? So in something that's acute, I would look at the most non-dependent areas. So usually in the ICU that's helpful because they're either lying flat on their back. So the most non-dependent area where the air is going to go is going to be anteriorly. And then also if you sit them up at 30 degrees or so, it's going to be up near the apex, and that really helps. Honestly, usually if we look at, so the long answer, the good answer would be the more thorough you are, the better you can confirm it, the more spaces you look. I'll usually look in maybe 2, maybe 3 rib spaces in the right non-dependent zones and be pretty confident about that. Especially if it happened acutely and you look and you see sliding. We do it when we run to code blues a lot, we'll bring the ultrasound with us, and that's one of the things we look for in those situations right away too. But usually a couple rib spaces in the most non-dependent area is pretty good. So some of the literature can back up how sensitive this is. So we typically would say when you see lung sliding, you virtually rule out pneumothorax in that area. There's a lot of data behind this. I pulled out what I think are my 3 favorites. So I like these because there's 3 large meta-analyses that this is the sensitivity and specificity combined of those, the range. So they range in sensitivity from 78 to 82%. To me, a tighter range means it's probably more accurate because they're very similar. Specificity is somewhere in the 98 to 98.4 range. So they all very similar. And you might say to yourself, okay, that's, only, not even 80%. That's really not that great at picking it up. Then you think about chest x-rays. So generally speaking, any study that has compared ultrasound to chest x-ray, ultrasound wins virtually every time. I don't know of any study where it hasn't. And in most of those studies, the sensitivity of a chest x-ray picking up a pneumothorax is only about 50%. So if you've ever looked at a chest x-ray and felt confident, okay, there's no pneumo here, you should definitely feel confident about the ultrasound, if that puts things in perspective a little bit. You can actually use more tools than just the lung sliding. So as I go through this, if you see any of these other patterns, the beeline pattern, the consolidated pattern, that the only way you get that is if there's no pneumothorax. So it helps exclude that as well. So, but this is kind of an algorithm that one group put out there. If you see the lung sliding, no pneumothorax. If not, but you do see some B-lines, then that would go along with no pneumothorax as well, because the 2 pleura have to be touching. If you didn't see B-lines or lung sliding, but you saw a lung point, then you should be highly suspicious for pneumothorax. All right. Any questions about the A-line pattern before we move on to the B-line? Okay, very good. So B-lines, unlike the horizontal A-lines, B-lines are nice vertical lines that start off at the pleura. They go all the way down off the screen, and they generally get a little bit wider as they go down. Move with respiration. So as the patient breathes and the pleura slide across each other, you'll kind of see these spotlight-looking B-lines go back and forth. If you saw an A-line sitting there and the B-line came across and hit it, the A-line should disappear, and all you should see is the B-line. So if it has all those criteria, those would be the B-lines. And what that really represents is the lung going from something that's pure, mostly air, and just being a big dense reflector behind the pleura. Now you have a lung that's a little bit more dense, so it can carry some of those sound waves down intermittently. And that can come from a little bit of pulmonary edema, stuff in the alveoli, interstitial findings, different things like that. So these are just some examples of that. So up here at the top, you usually need the phase array probe for this to get the adequate depth. So you can see up here the pleural lines at the top. This pleural line, unlike that other nice thin smooth pleura, is a little bit thickened, it's raggedy. And then these B lines come down all the way off the screen to the bottom. And you can just see those kind of move back and forth as the patient breathes. And right here, you'll see there's almost a little hint of an A line that disappears whenever the B line kind of comes across. Okay? And these B lines can be very thin and very distinct, separated from each other, or they can be a little bit wider and start to coalesce as it gets more severe. In COVID, we saw a lot of this. We also saw a lot of this, where you get completely confluent B lines from just really severe pneumonia. So generally speaking, you can see 1 to 2 B lines within a rib space and it not be pathologic, particularly in the lower west zones of the lung, where you see a little bit more blood flow due to gravity. So there's a little bit more fluid sort of within the tissue. Typically, if you're up anteriorly, even 1 or 2, I would start to be suspicious, might not be normal. Like I said, with the B lines, if you saw them in only 1 zone of the lung, you'd be suspicious for pneumonia in that area. If you saw it pretty diffusely, you're thinking more things like ARDS, cardiogenic pulmonary edema. Typically speaking, the more B lines that are there, the more severe the disease. And then other things that can really help you differentiate between cardiogenic pulmonary edema and some other process is going to be looking at that pleural line. Nice, smooth pleural line goes along with cardiogenic pulmonary edema. Jagged or broken up is going to be something else. Pneumonia, ARDS, interstitial lung disease, something like that. And this is basically just a paper kind of showing that. So they called it alveolar interstitial syndrome, basically having more than 2 B lines in a rib space. And if you had things like pleural line abnormalities, went along much more with ARDS than cardiogenic pulmonary. This is just an example of that here. So here you have the pleural line. Again, it's kind of broken up a little bit rather than that nice smooth appearance. You can see, it's a little thicker, jagged parts with the sort of either B lines or pseudo B lines coming off. So this was somebody we intubated, they had bilateral infiltrates, and this was ARDS. All right, questions about that before we talk about?
Similar question. So
Yes.
if you get a pneumonia, like they've got a consolidation, that's probably gonna give you the B lines. So if you had an unaffected so how, sounds like you probably do more checking than if you're looking for
That, yeah, if you're looking to try to do that, then you're being a little bit more thorough. And I think that's one of the limitations too, is how thorough are people routinely, because it's not, even when we save them in the chart and things, it's really important to label them so people get a sense for how many different zones you've looked at. We tend to focus a lot where we know there's an abnormality or we're concerned there's an abnormality. But I think in using it, you kind of develop your own protocol on kind of what you're looking for. If I was just scanning for pneumonia, I'd probably be pretty thorough looking everywhere because it gets a little bit hard to tell. But I've got some other good examples that I'll kind of show you how that regional aspect works. So we'll go now to the C pattern or the consolidated pattern. Go ahead.
Quick question. There was the sensitivity data. Very sensitivity data regarding pneumonia using that.
Yeah, that data is definitely there, and they did a lot in COVID as well. So generally, it can be more sensitive than a chest X-ray for some of these subtle findings. CT is probably the gold standard, so it comes pretty close, but I don't have a specific number for you off the top of my head. But it's generally a little bit more sensitive than chest X-ray for you to pick up those things. Sometimes almost you have to know kind of the context of how you use that. It's just like a CT, you pick up some little abnormality and then you have to decide, okay, is that something to worry about or not? But good question. Yeah, he was just asking about the sensitivity of lung ultrasound for pneumonia compared to X-ray. Yeah. Exactly. So we'll go through pleural effusion, but that's something you can also see in CHF exacerbations that would maybe point you that direction as well. But the B lines can be either pneumonia or pulmonary edema. It just kind of depends on the overall pattern. Any other questions? Good. All right, very good. So consolidated pattern is the last one that we'll see for the lung finding specifically. So in this situation, the lung gets even more dense and it starts to have almost more of a soft tissue density that now picks up more of the sound waves and they travel through it. So some people call this the hepatization of the lung, but it starts to look very similar to the liver. In some situations, you can see these little white or what we call hyperechoic dots in it. And what those typically represent are essentially air bronchograms in the ultrasound version. So the sound waves come in through the dense tissue due to edema, due to atelectasis or pneumonia, whatever's going on there. And then it hits some air trapped in the airways and it scatters and just creates like a little circle. And if that air bronchogram moves back and forth when the patient breathes, it's slightly more suggestive of it being a pneumonia, what we call a dynamic air bronchogram. If it's static and not moving, then that is a little bit more suggestive of atelectasis, but I wouldn't put a ton of stock in those. It's pretty hard to tell those two things apart. And just to give you examples of that, so here we have same thing. Now we're using that phased array probe, as you can see from the triangle. This dense structure down here is going to be either the liver, the spleen, depending on which side of the body you are on. Generally, this one I would bet is liver just based on the size. The spleen is a lot smaller. And you can get a little hint of the bright white diaphragm right here. And then this big triangular structure is that consolidated lung. And it just kind of gets down and it hugs the diaphragm. And you can see these little white dots are the air bronchograms. And the whole lung is moving, but if you ask me, these are not moving within the lung. So I would call these static air bronchograms. This is probably more suggestive of atelectasis, but I sure wouldn't hang my hat on that versus pneumonia just based on an ultrasound image like this. You can see a little bit of a hint of this dark anechoic area at the top. So that's just a little bit of a pleural fusion, probably a little pleural fusion down here as well. And in lung ultrasound, sometimes you'll see it mixed patterns, and I would always describe it as the predominant pattern. So is it big effusion with some squished allopathetic lung, or is it a lot of consolidated pattern with a little bit of effusion that's probably sympathetic from the pressure being changed due to the allopathetic lung? So this would be the latter.
On this image,
Mhm.
since you're not seeing the current would you say this figure is more electric?
Either atelectasis or pneumonia, because the curtain sign should really be there. It's a good that you know about that. So basically what that is, he's asking about whether or not the curtain sign, if that's, since the curtain sign is not there, would that be more suggestive of pneumonia? So that the curtain sign is basically air-filled lung that when you're looking at the diaphragm, the patient takes a breath in and the air-filled lung now comes down in between your probe and the underlying structure of the diaphragm. So it scatters all the sound waves. You see the liver, and then you see just air pattern, the A-line sort of pattern in some situations, or you can't see anything. And that's good for ruling out pleural effusion. In this situation, the whole time there's some density in between your probe and the liver. So it doesn't really tell you per se about lung versus or pneumonia versus atelectasis. All you know is that what should be aerated lung now has a soft tissue density in that area, which is why you can see it the whole time. I think I might have an example of the curtain sign in here later. This is just another example of a consolidated lung. So this one is very severely consolidated. You can see down here at the right-hand side of the screen is the spleen. I know this because this was a younger lady who actually had a cardiac arrest and wound up in the ICU, and we ultrasounded her afterwards and found this really dense pneumonia. So you've got some of those dynamic air that move back and forth as she breathes. You can see right there it is. See how they kind of move in and out as the air comes in. These dark areas of things here, what do you think those might be if they're dark fluid density within the lung? That's actually pulmonary vasculature, which we don't see very much. That's just how consolidated her lung was in this situation. And you can see down here, this bright white is actually the spine. The sound waves are just traveling through this dense consolidated lung so well that you can the spine below. And that's actually another sign looking for pleural effusion, if it's carrying the sound waves quite as well. This is just another example of consolidated pattern. This is done in that lung ultrasound exam. I told you in the beginning that we don't really like this mode. We usually set it in the abdominal mode because of the harmonics. And you can just appreciate how much grainier this is and harder to actually kind of delineate some of those structures. So this is why most people that do a lot of ultrasound don't actually use the lung exam mode within the ultrasound machine, which is FDA regulated, I learned later. This is why they're all like that. I don't know why, but that's fine. So this is just to give you a regional example. So this was a patient with COPD admitted for pneumonia. And essentially what I'm doing is I'm starting with the probe down here in the area that is a little bit more aerated. And then I'm just sliding up individual rib spaces. You can see it goes from an A-line pattern to a B-line pattern. And I move up and then you get a little more B-lines. And then I slowed the image down for the next rib space. So you can see I'm looking just one rib space to the next. And you'll start to see that consolidated pattern there on the left-hand side of the screen. So it just was a really soft pneumonia. And it was very prominent to see the difference because of his underlying COPD. So that's it for the consolidated pattern. Any questions about that otherwise? So we'll talk now a little bit about pleural effusions. So they're typically going to be found in the lower posterior region. It's best if the patient can sit up or at least in the semi-recumbent position. You should always identify all the structures around it is what I tell my fellows. So if they're ever going to put a needle in anything, I want them to tell me show me the kidney, show me the liver or spleen, depending on the side, diaphragm, and then you should see some atelectatic lung floating within the fluid and then the fluid pocket. So I'll just give you some examples of that. When we see pleural effusions, we break them down by a couple descriptions. So they can be simple anechoic and black, meaning it's pretty free flowing. Based on the literature, still up to a third of those are potentially exudative, so ultrasound is not good enough to look at it and tell you definitively one way or another, with one exception, which I'll show you. And if we see anything in the fluid at all, we call that a complex pleural fluid effusion. If it's just free floating, that's a complex non-septated. Once you see little bridging and fibrosis built in there, we call that a complex septated. The complex septated is exudative virtually 100% in the literature. There might be a case report out there. I look intermittently and I cannot find one of a transidative septated complex effusion, and so far there aren't any yet, so I'll keep looking. So this is just an example of what that would look like. I'll show you the video in a second, but just to orient you, again, to the right hand side of the screen is going to be the liver, spleen. Bright white arc is going to be the diaphragm. All this is pleural fluid, and then this is the atelectatic lung inside there. So you can see as the patient breathes, the video go, there we go. This person was actually working pretty hard to breathe, which is why you see everything move quite a bit, but you can identify all those structures in there. Just another example. Here we've got the beam tilted a little bit, so you can see the kidney down below in the beginning of the clip, then the liver, spleen, and then the pleural fluid with the lung flapping inside there. This is the example of that curtain sign that you were talking about. So basically, you're looking with the transducer, and you're seeing some kind of soft tissue structure. The diaphragm is that bright white line, the arc over here, there on the left-hand side of the screen. And then as the patient takes a deep breath in, aerated lung comes down as the diaphragm moves, and then you can't really see anything except the aerated lung. So the reason this is helpful in ruling out a pleural effusion is because you're looking right where that dependent fluid should be, and you're seeing liver, and then they take a breath and you're seeing lung. So there's really no space for that fluid to hide. And again, you want to be thorough. So if you would look from the side, then I would typically kind of slide the probe all the way around the back just to make extra sure. Particularly if you were worried about it, if the x-ray was abnormal or something like that. This one, you can also see a little other thing that gives you a hint is right here. If you look just above the diaphragm to the left, it looks very similar to this right here. And that's actually what we call a mirror image artifact. So ultrasound waves come down, they hit the liver or spleen, they bounce off of the dense diaphragm with air density on the other side and come back up and generate the same image as the thing below the diaphragm. Again, that only happens if you have air above a density like the diaphragm. So it helps you exclude pleural effusion in that area, because if it were fluid, it would just keep taking those sound waves further and you see it. This is just demonstrating that spine sign. So you generally should not see the spine through the lung, because on the bottom, they have nice aerated lungs. So you can see it, the soft tissue density of the liver takes the sound waves all the way down to the spine here, but above the diaphragm, air is blocking it. If you do see the spine above the diaphragm, there's pleural fluid there or something. Occasionally that really dense consolidated lung, like I showed you, will do it. But if you see the spine above the diaphragm, you should be worried that there's either some fluid or pneumonia or something going on. The bottom one is normal, and the top, oh, not because they ain't playing yet, but yeah. So if we say positive spine sign, that means that there's some fluid there, or you're seeing the spine of the diaphragm. This is just an example of a complex non-septated effusion. So we did this one in cardiac, as you can see, which we're not supposed to do, but occasionally it happens. So the orientation marker now is toward the right-hand side of the screen, so everything's flipped. So now the spleen or diaphragm is over here, spleen or liver. Diaphragm is the bright white line over here, and then the atelectatic lung is on the right-hand side of the screen. And you can just see that pleural fluid there now has something floating in it. A little more echogenic particles, proteinaceous material, blood sometimes can do this, and higher levels of protein. So in the literature that's out there, there's surprisingly few studies, but the literature out there would say that this now really only has about a 55-ish% chance of being an exudate, so still about translate about 45% of the time. So again, it doesn't help you necessarily distinguish, but it maybe raises your pretest probability a little bit. This is what we call a complex septated effusion. So you can see here on the, again, we have this one flipped too, unfortunately. but the diaphragm is over here, liver or spleen with a little bit of ascites down below the diaphragm, and then that pleural fluid has all this little stuff floating in there. This is either a hemothorax or an exudative effusion, virtually 100% according to as far as the literature out there goes. So this, we would have a very low threshold to put a chest tube in. All right. If I have one case to go through just to show you how this can make a difference even when you don't think it will, but I'm happy to answer any other questions before we go through this one. Okay. All right, well, let's run through this real quick. So 70-year-old male, history of hypertension, AFib, presented to the ED with altered mental status. In the ED, he was found to be bradycardic. They intubated him in the ED. They floated a transvenous pacer wire. His heart rate improved to the 80s. We had talked to his wife, who said that he had a significant heart history and he really hadn't been taking care of himself. They'd noticed worsening bilateral lower extremity pulmonary edema, bilateral lower extremity edema. His chest X-ray looked like this. So we looked at it on rounds and we thought, okay, really dense kind of meniscus looking stuff down at the bottom, maybe a little bit less and less as you go up. So we thought it was a, layering bilateral pleural effusions. The radiologists, for what it's worth, agreed with us. They said bilateral pleural effusions. And then we said, well, let's just bring the ultrasound in, just because we like ultrasounding things, right? So we went in there and we looked, and I'll show you the right lung and the left lung. And they're not the highest quality images because he was a pretty big guy, but I can hopefully convince you at least. Let's start with the top one. So we see that arc over here intermittently is the diaphragm. And then we see that kind of speckled consolidated pattern. And that was actually more atelectatic pneumonia looking. Same thing on the left side, spleen smaller, diaphragm, no real fluid, but definitely consolidated pattern with that air bronchograms. And the reason I think this is at least interesting is because the joke at the door before I'd even seen him was, well, are we going to give him 80 Lasix or 120 Lasix? And then we actually walked in the room and did it. And we said, you know what? Let's cancel the diuresis. Let's do some more IPV, try to open those lungs, and let's broaden his antibiotics a little bit. So it really can make a big difference. And the times I noticed it make the biggest difference is when I already thought I knew the answer before I brought in the ultrasound, and it totally changes the opinion. So that's all I've got for you. So I'm happy to take any questions. Go ahead.
Okay, so this is not really related to like the technique, but as far as billing, like if I'm learning this kind of stuff when I'm out in the real world, if I see something that I think is concerning, if I get a different imaging modality to confirm, like if I get an X-ray, I can still bill for it. But if I do a lung ultrasound and then I order a lung ultrasound to confirm it, like can I not bill for what I've done?
Yeah, so the question was about billing for it, and if you're trying to confirm things in different modalities or the same modalities, will you run into billing problems? So complicated question, but a good one, and let me walk it through a couple different parts of answers. So number one, ultrasound billing, the few things you need is you need an indication, you need to be able to save and archive the clips that can stay in the chart so somebody can come back and look at them later, and you have to generate a report that says you looked at it and this is your interpretation. If you have all those things, you can bill for it. In terms of it running to other billing issues, so good. I guess my first thought would be good luck ordering someone else to do a lung ultrasound, because I don't think it's a radiologic study that exists, to be honest. But in general, it should not cause other problems with ordering other modalities. It's just like now your indication could be abnormal lung imaging, and that's why you're getting a different study. So I don't know if different insurers are going to be really picky, but this is something that you could do in your office. And we actually do have archiving abilities with Epic on the inpatient side. I don't know that anybody's got it too much to the outpatient side yet, but it's definitely something that you could bill for in that situation. And the plus side is you're not fighting anybody for the billing because nobody else is doing it. In terms of repeat exams, they have different codes for repeat exams. So we'll do repeat ones inpatient all the time. So if we do one the first day, identify the effusion, put the chest tube in, 2 days later, we want to see if we got all the fluid out, you can do that and rebill it. It's just a repeat exam. Other questions? Any questions from our virtual audience? No. Okay. All right. Well, thank you very much for your attention. Happy to be here.